Well, Doc, I mean, there's probably some people out in the clinic right now. And so if you need to get going, like if you think it'll take the rest of the time, then go for it. And then as people come in, they'll hear you talking and then they can hop in whenever they can, but
All right.
still working.
All right, we can do that. So I'm James Carillo. I'm a clinical assistant professor at the University of Iowa. In July, it'll be 40 years that I've been doing anesthesia since when I started my residency. I started my residency 40 years ago in July. And my area of interest is opioid minimization. So I did 30 years of private practice in California. And then I've done cardiac anesthesia for 10 years. And I basically did general anesthesia and OB and things like that. I left private practice I'm interested in opioid minimization during general anesthesia. So that's kind of what I'm interested in. So this is the overview of what I want to try and talk about is my plan was to try and do this in 2 presentations, do my talk today and then do another one on medications. I was made aware that you guys had a pharmacology presentation yesterday. So if you guys want to go ahead and do that, maybe not. But in order to really get through this, I think the slides I have I'm not going to be able to cover them all in 30 minutes. So I can come back and finish the back half of my slides at a second time. But we're going to go over the practice. So the overview of what I want to cover today are the practice guidelines for moderate procedural sedation. It's a PDF I sent to Ari, and I can send, can be sent to all of you. It's a great document, great resource for procedural sedation. Next, I want to just talk about the harm that can occur from moderate sedation. Next, go through the ASA sedation scale continuum, actually define what moderate sedation is. Next, I want to really address the fact that in moderate sedation, you have a spontaneously breathing patient, which means they have an open airway, and the open airway presents the risk of aspiration. So I want to make you guys aware of that. Next, I want to talk about the mechanism of airway obstruction and hypoxia, and I want to make a comparison between moderate sedation and what happens in sleep apnea, and it really has to do with loss of hypopharyngeal tone. Next, I want to just talk about the fact that you all have doctorates in dentistry, and the fundamental information that you guys know are experts in is a great foundation to have great success if you decide to do moderate sedation yourself. Then I think these other things, the perioperative phases of care, I think I might do in a second talk. These are the practice guidelines for moderate procedural sedation. As I said, we'll send you this PDF. It's a consensus document that's made up of medical anesthesiologists. The American Society of Anesthesiologists actually made this task force. They included oral maxillofacial surgeons. They had input from the ADA, so dentists. They had input from the American Society of Dentist Anesthesiologists. And they also had 2 radiology groups be contributors to the consensus that they came up with for these guidelines. The only 2 things that I want to say is this name down at the bottom that I have highlighted is Dr. James Tom. He's a dentist in Los Angeles at USC. He was the man that was responsible for getting the ADA to approve dental anesthesia as an approved ADA specialty. So he's a pretty special guy, and he was one of the contributors in this. Other things that I want you to be aware of, and maybe I can show you at the end, is that this document has an appendix that has a lot of useful charts and information. It talks about NPO guidelines, the things that you need to have available in the operating room, if the equipment that you need and the drugs. It talks also about the sedation scale, and it talks about recovery parameters. So it's a very important document if you're interested in doing procedural sedation. The other thing I want to back up and say is that some of you might not really be interested in doing procedural sedation, but when you become dentist in practice, you might consider you want to use moderate sedation in your patients, because if you do this, you'll be able to increase your patient demographic, increase the potential number of patients you could treat, grow your practice. And the reason for this is you can start including pediatric patients. You can include special needs patients. and you could include adults who have extreme anxiety about going to the dentist. So even if you yourself aren't interested in doing moderate sedation, hopefully the information in this talk will make you aware of the challenges and the way and the challenges, the risks, and how to, and the process to really optimize safety. So this, I just found one article really talking about deaths related to dental treatment. It was a systematic review. It basically looked at 56 years worth of reporting. There were 148 fatalities reported in this period of time. I'm sure this number is underreported. Really, the point of this isn't necessarily the numbers as much as the fact that you can really harm somebody with moderate sedation. Basically, they looked at 56 years of experience. It came out to be 2.6 deaths out of this 148 fatalities in the group. The leading causes of death were anesthesia, sedation, medication complications were responsible for 47% of the deaths, but airway compromise, 12%. What I found in my experience is that the complication that really causes the greatest harm and risk to a patient during sedation is if the airway obstructs, and then it becomes an airway issue of hypoxia. People get hypoxic, that's how they arrest and get brain damage. So I'm going to combine these two together and say that I would say 60% of these deaths were really due to sedation and airway issues. 21% of the deaths were due to cardiovascular events. So the takeaway message here is that safety is dependent upon a process and upon being prepared. This is the ASA sedation scale continuum, and so it goes from light to deep. The parameters that we have across the axes are that we have minimal definition of minimal sedation, moderate sedation, deep sedation, and general anesthesia. The variables that we're going to look at in patients is their responsiveness, their airway, and what I mean by airway is that is it opened or is it collapsed? Spontaneous ventilation is really derived from the brainstem, where there's a respiratory generator that basically stimulates the diaphragm to breathe, and then cardiovascular function is heart rate and pulse. So I have this color-coded minimal sedation. I use blue to think of as like a blue sky on a warm summer day that's not threatening. Basically, what you have here is cognitive function and coordination may be impaired, but the airway, spontaneous ventilation, cardiovascular function, and responsiveness by and large are all normal. Green is really where you want to be. This is moderate sedation. The hallmark of moderate sedation is that you have a patient who can follow the verbal command, take a deep breath. And so it's important to try and keeping in verbal contact with the patient, preoperatively making them aware you want to make them aware that they're not going to be so deep that they're not going to be able to hear your voices. I try and describe to them that they're going to be in a state where they might be aware that they're in the operating room or having a procedure, but they're not going to care. So they're going to be aware, but they're not going to care. They're going to be able to follow verbal commands, but they're going to be able to tolerate the procedure. The other parameters to look at is during moderate sedation, you want to keep this verbal contact with the patient. Also light tactile stimulation, like kind of rubbing their, shaking their shoulders is also part of this, that if that's what it takes to get them to take a breath. Typically, no intervention is needed for airway, spontaneous ventilations, or respiratory function. This is where you want to be when you're doing moderate sedation. Deep sedation is what you described earlier, having to pull the tongue or, pinch the ear. This is really where you've lost verbal contact with the patient. And so as a result, they only respond to purposeful, repeated painful responses. At this point in deep sedation, intervention of the airway might be required, and that would really be this ramus lift that I talked about, the chin lift jaw thrust maneuver. Basically is just taking taking advantage of the TMJ joint, moving it, the translational property of it, where you move the mandible away from the posterior pharynx. It typically opens the airway. Spontaneous ventilation may be inadequate, and hopefully the respiratory drive hasn't been depressed such that when you open the airway, the patient will continue to breathe. and cardiovascular function is usually maintained. General anesthesia is defined as the loss of verbal contact with the patient and the loss of the ability of the patient to respond to repeated and painful stimuli. At this point, typically they're not arousable. Typically, at this point, you're most likely going to have the jaw thrust maneuver is not going to work. You'll have to probably do bag mask ventilation with an ambu bag. Frequently, the spontaneous ventilations are not adequate. That's why you need the bag mask ventilation. And cardiovascular function may be impaired. You might have to give vasopressors to deal with hypotension. You might have to give something like glycopyrrolate to increase the heart rate. Next, I want to make you aware of basically moderate sedation is really going to be what we call monitored anesthesia care, or MAC. And the characteristics of moderate sedation is that you have an open airway. This means that you now have the risk of aspiration of foreign bodies from the dental procedure and also the gastric contents of the stomach. Materials, there's a reference in the, I have a reference in the bibliography talking about the actual aspiration of dental materials that have been reported. And one of the points they bring up is that the different materials that are used have different radio densities. And so some of them really are not, you're not able to see with X-ray, which can be a real problem if you're trying to then have to have somebody go down and actually extract these at a later, kind of emergently or whatever. So the material you're using and its radio density is important. Blood and tooth debris can also be aspirated. So the prevention is to use throat packs, dental dams, and timely suctioning. Gastric contents are really the risk of, is really the greatest risk to an open airway. It's why patients are made NPO before anesthesia. And it's the leading cause, well, the reason that your gastric contents are so caustic is because you can get an aspiration pneumonia. There was an obstetrician in the 1950s, Mendelssohn, who in the 1950s, the leading cause of anesthesia-related death during C-sections was aspiration. And what Mendelssohn realized is that the pH of the stomach and the quantity of gastric contents aspirated were directly correlated to the severity of the aspiration that could actually lead to death. So the open airway is something that really must be respected, and there has to be an awareness of it. General endotracheal anesthesia, on the other hand, is general endotracheal anesthesia, is where we place an endotracheal cuff. This protects the lungs from aspiration because there's a cuff on the endotracheal tube. It allows positive pressure ventilation with a ventilator, and it can also, we can then use paralytic agents and medications that take away a patient's ability to breathe. Yeah, I'm not trying to insult anybody not knowing what a tube is, but this is an endotracheal tube. There's a connector here that an ambu bag can connect to, or anesthesia circuit. There's here a pilot valve that a syringe goes into, usually put anywhere from like 5 to 10 cc's of air in this cuff. It creates a seal with the trachea and would prevent material from entering the lungs from the oropharynx. And then it also from below would allow positive pressure ventilation by creating a seal. This is kind of a little bit of a complex slide, but what I want you to really be aware of is that there are two mechanisms underlying breathing. There's the respiratory drive center in the brainstem, and then there's also the hypopharyngeal tone. So the respiratory drive center is the basically generates breaths through the phrenic nerve to the diaphragm, and it by stimulating the diaphragm to contract, it creates a breath. The respiratory drive center is in contact with peripheral chemoreceptors that can sense hypoxia and hypercarbia, decreased oxygen and increased carbon dioxide. Both of these are stimuli for the respiratory brain center. That is, when these levels go down, when oxygen goes down or CO2 goes up, the respiratory drive center impulses, it generates more breaths. So it stimulates breathing. Just taking a look over on this side here, this is kind of a diagram of like, this is the nasal segment and the tracheal segment, and they're both rigid and therefore not collapsible because they have bone and cartilage to keep them open. However, the hypopharynx is collapsible. So the pharyngeal component of the hypopharynx is collapsible, and that's where snoring and apnea can occur from loss of hypopharyngeal muscle tone, which is also what happens during sleep apnea. So basically, the respiratory drive center is like a pump. So the respiratory drive center is pumping a drive to form breaths by the diaphragm. There's also a hose. If you think of a pump model, there will also be a hose. If the hose gets obstructed, the pump's still working, but the hose is closed. And so by opening the hose, you can then restore flow through the pump system. And this is really what happens when hypopharyngeal tone is lost. One other function of the respiratory drive center is that the wisdom of the body knows that if you look here, that air would be coming from the mouth to the lungs. If you can just imagine a negative pressure here with a collapsible hypopharynx, you could get closure of the hypopharynx to cause apnea. The respiratory drive center during inspiration actually sends impulses to the hypopharyngeal muscles to stiffen, because this negative pressure that's going to be a force to oppose the potential collapse from this negative pressure going down into the lungs. So hypopharyngeal tone is very important. It's increased during inspiration coming from the respiratory drive center, and also wakefulness. During wakefulness, hypopharyngeal tone returns. Sedatives like fentanyl and midazolam can decrease the hypopharyngeal tone, causing collapse. And the way you'll know this is at first it'll be snoring, and then the snoring will actually progress to apnea if this keeps progressing. So these are really important things to be aware of with why people stop breathing or have difficulty with breathing, and therefore oxygenation levels start going down. This is really the mechanism for why that occurs. So again, just kind of trying to review what we just said in the prior slide. So breathing is dependent on both the respiratory drive center, the hypopharyngeal muscle tone. The hypopharyngeal muscle tone can be depressed by opioids, either alone or in combination with midazolam. The respiratory drive center, as we said, increases hypopharyngeal tone during inspiration. It's present during wakefulness. Now, the model in sleep apnea is really interesting. During sleep apnea, in REM sleep, during REM sleep when we're dreaming, that's where the majority of dreaming occurs, loss of postural muscle tone occurs. And it's believed teleologically that this is so that we don't act out our dreams. If your muscles are all paralyzed, you're not going to be able to like swing your fists or even get up out of bed and try and start running. So it's kind of a protective mechanism. Anyway, during sleep, during REM sleep when we're dreaming, you lose muscle tone. So the hypopharyngeal muscles are included in the muscles that lose their tone. So as a result, the tone is lost, apnea occurs. What happens then is carbon dioxide levels start going up, oxygen levels start going down. As a result, it's believed that the hypoxic signal is what causes wakefulness. With wakefulness, hypopharyngeal tone returns, and therefore breathing is resumed. Typically, if the respiratory drive center is depressed with much higher doses of sedatives than the hypopharyngeal muscle tone. So hopefully the respiratory drive center is still operational when you have a patient who's starting to get apneic. So just by opening the airway, the respiratory drive center, the pump, will then be able to get air through this collapsed hypopharyngeal muscle tone area of the hypopharynx. The chin lift and the jaw thrust in the OR are ways to relieve this. I want to just show you how to do this. This is a video to show you how to do this.
The head tilt maneuver moves the neck and is thus contraindicated in a patient who might have a cervical spine injury. To do the head tilt chin lift, tilt the patient's head back by pushing down on the forehead, and then place the tips of your index and middle fingers under the chin and pull the mandible up. This lifts the tongue away from the posterior pharynx and improves airway patency. The jaw thrust maneuver does not cause much motion of the neck and thus is preferred over the head tilt chin lift maneuver if there's a possible cervical spine injury. Stand at the head of the stretcher and place your palms on the patient's temples and your fingers under the mandible. Next, lift the mandible upward with your fingers. This maneuver lifts the tongue along with the mandible, thus relieving upper airway obstruction.
All right, so that's a really important thing to be aware of. And then, so basically, so now what happens is if apnea occurs from loss of hypopharyngeal tone, this chin lift draw thrust maneuver will work because the pump's still working, but the hose is collapsed. However, if apnea occurs from the loss of respiratory drive from the brainstem center, this is going to require positive pressure ventilation because the patient is not getting stimuli to start to breathe. It's not getting any stimuli. It's not getting information from the brainstem telling the diaphragm contract and start breathing. So as a result, you have to take over the function of breathing for them by using bag mask ventilation. So here's
Bag valve mask ventilation can be done with one person or two. In both cases, successful ventilation depends on three things: a patent airway, an adequate mask seal, and proper ventilation. A patent airway is achieved by inserting an oropharyngeal or nasopharyngeal airway. To do the one-person technique, hold the mask in your dominant hand. The web space between your thumb and index finger should be wrapped around the connector stem. Lower the mask onto the patient's face. First place the nasal portion of the mask over the nose, and then lower the body over the patient's mouth. The bridge of the nose, the two malar eminences, and the mandibular alveolar ridge must be covered by the mask in order to achieve a proper seal. Make sure you do not place your hands or the mask on the patient's eyes. Doing so may damage the eyes or cause a vagal reaction. Place your middle, ring, and little fingers under the patient's mandible and pull it upwards into the mask. This maneuver is similar to that of the head tilt chin lift technique, and it further opens the airway. While these fingers maintain upward traction on the mandible, the thumb and index finger hold the mask tightly to the face and ensure a proper mask seal. If your hands are large enough, your little finger may be placed behind the mandible and do a jaw thrust maneuver to further open the airway. Be sure to pull up only on the bony parts of the mandible. Pressure to the soft tissues of the neck may obstruct the airway. Once a good seal has been achieved, begin to ventilate the patient. In most cases, the ventilatory rate should not exceed 10 to 12 breaths per minute. Use a tidal volume just large enough to cause the chest to rise. Two-person bag mask ventilation is easier and more effective than the one-person method and should be done if possible. In this technique, one clinician maintains a proper mask seal while the second clinician squeezes the bag. The more experienced clinician should handle the mask because this is the most difficult part. The first clinician holds the mask in a fashion similar to the one-person technique. The web spaces of the thumbs and the index fingers are placed adjacent to the connector stem, and the mask is lowered onto the patient's face, nasal portion first. The middle, ring, and little fingers are placed under the mandible and pull it upwards. The thumbs and index fingers hold pressure along the superior and inferior portions of the mask. Once a proper seal is achieved, the second clinician attaches the bag to the mask and begins ventilation. Note that the first clinician may provide a head tilt and a jaw thrust maneuver while holding the mask onto the patient's face. Observe for proper chest rise during ventilations. An alternative method can be used in which the stronger thenar eminences hold the mask to the face. The first clinician puts the base of his thumbs parallel to each other along the lateral edges of the mask. The mask is then lowered onto the face, and the fingers are placed under the mandible. The mask is pressed to the face with the thenar eminences while the fingers pull the mandible upwards. Chin lift and jaw thrust may be applied concurrently. This technique is easier to perform, allows the use of stronger hand muscles to maintain a proper seal, which minimizes fatigue, and enables 4 fingers rather than 3 to do the chin lift and jaw thrust.
So those are really important things. Other things I want you to be aware of are some adjuncts. So this is called a mask strap, if you can see it. this is called a mask strap. And what it does is it goes behind the back of the patient's head and it comes up here. And typically masks have like hooks. And so you can actually, this is elastic too. So you can use this to really make a really good seal of the mask on the patient's face, so that you then have to, all you really have to worry about then is just really with 2 fingers on the ramus, you can lift the ramus and actually open the airway. So this is like a really important thing to consider having if you don't already have them in your facility. Other things 2 other things I'd like to talk about are this is an oral pharyngeal airway that was in one of those videos. This goes inside the patient's mouth and opens the airway. Usually it's the velo-palatine area that is the primary area of obstruction. And this tends to really open the airway that way. So this is called an oral pharyngeal airway. This is a nasal pharyngeal airway. It goes in the nose. I'd say I really give you great warning with these because you can cause nasal bleeding with one of these. And if you have a difficult airway, somebody who's not breathing, that you're have to start trying to ventilate, and if you then have to actually have somebody intubate, bleeding can really cause a big issue. So just be aware, like an ACLS, what they recommend is that oral pharyngeal airway should be placed in somebody who's unconscious, whereas a nasal pharyngeal airway in somebody who's not totally gone. But I have to do the caveat that bleeding caused by these can really make a difficult situation really, really bad. Right. So the recommended practices. I don't really have slides about this, but the head up position, but the whole thing of like putting a patient's head up versus supine, like being horizontal, can actually increase the oxygenation in the lungs. And so, for example, somebody going from supine standing position to supine can actually lose 700 to 1,000 mLs of functional residual capacity of lung space. And the mechanism for this is that when we go supine, gravitational forces now allow the abdominal contents to push up on the basilar portions of the lung and cause compression atelectasis of the lungs. This is more exaggerated, and as BMI increases, this effect is even greater. So people with big abdominal penises and a lot of heavy weight on their chest will also accentuate all of these properties. Just by putting the head up causes gravity to pull the abdominal contents away from the basilar portion of the lungs. It'll make it easier for you to ventilate somebody. It will increase the reserve, the functional residual capacity, which really means you'll have a greater period of time before the pulse oximeter is going to start dropping. So when you have a patient, like if you get a morbidly obese patient with sleep apnea, they're going to be at very high risk to obstructing this hypopharyngeal tone business that we talked about, occurring much greater in them, plus these gravitational effects causing atelectasis in the lungs. So by trying to make a compromise with your dentist, the proceduralist, as to the height of the patient's head, so actually just putting the patient's head higher in the chair might be necessary for bigger people with those problems. That creates, I'm told by I have 3 kids who are dentists, that maxillary teeth are more difficult to see with the kind of the head up position. So you have to try and come to some compromise with the proceduralist to try and optimize oxygenation. So the head up position is really important. There are 2 references I have in the bibliography that talk about this effect, the difference between patients being supine versus head up. In terms of the safe apnea time, the amount of time it takes before the pulse oximeter is going to start dropping. So this is a really important thing. The recommended practice, I'm going to say, is use nasal cannula oxygen. Capnography, which is really end-tidal CO2, is really critical because the capnogram will pick up, you'll see apnea when it occurs because each breath the patient's making is made on the capnogram. If they go apneic, you're going to detect apnea long before the pulse oximeter starts dropping. A pulse oximeter drop is really a late sign, and capnography is really predicts that apnea is occurring, shows that it occurs, it is happening. It means that try and consider a jaw thrust, jaw lift. If for some reason the respiratory drive center is depressed and they're not breathing, you have to then have to go to the back mask ventilation. So basically, we hope for the we prepare for the worst and hope for the best. So capnography is a really important monitor. Airway collapse, we went over the chin lift and jaw thrust. Snoring will first start. When snoring happens, that's starting to be like the hypopharynx is starting to obstruct. With full obstruction, you get apnea. So snoring is kind of a sign that they're starting to obstruct. Minimize sedation and use nerve blocks. Some people might, some proceduralists might say, well, look, you're providing moderate sedation. Why do I have to give a nerve block? You're here to give anesthetic agents. That's not the way you should go with this. You should first of all, you guys are dentists and experts at blocks. A block should be placed. One, it's going to allow you to use less sedation and make it safer. Two, it's going to provide postoperative analgesia. Okay, so titrate the medicines in small doses over minutes, rather than just deciding I'm going to give 100 mics of fentanyl. Maybe give it like 25 at a time, waiting 2 or 3 minutes between doses, and then keeping verbal contact. Keep saying to the patient, take a breath. Marianne, are you okay? Okay, take a breath. And try and titrate. Titration is really the key, not some formula that I'm going to give 2 milligrams of Versed and 100 of fentanyl until the proceduralists go for it, because you're not going to really know what's going to happen. Every patient is really different in terms of how they respond to anesthetic agents. And the effects of the respiratory brain center and this hypopharyngeal collapse mechanism are really important to be aware of. And then, you have to maintain this verbal content, take a deep breath. That really is a monitor. That's a monitor saying I'm in moderate sedation, not deep. And then you also have to make adjustments for weight, age, the frailty of the patient. OSA is obstructive sleep apnea. The history of obstructive sleep apnea is really important because these people will tend to obstruct more with sedation. And then try and use reduce doses over a period of time. This is an example. This is a case that I did. This lady weighed 162 kilograms. She was having what's called a hysteroscopy, a polypectomy of the uterus, and also a DNC. So she was really motivated. The other thing with sedation, with moderate sedation, is that you have to have a patient who's motivated and realizes, you don't want a patient that said, look, I just don't want to know anything. What you have to explain is, look, you're going to be in a state where you're going to be aware, but you're not going to care. All right. I want to, for your safety, I want to be able to keep verbal contact with you. You will be able to tolerate the dental procedure. That's not going to be a problem. And if you can try and give them, at least prepare them for that, so they're not freaked out when it's happening, it's really important. So this is this is the end tidal monitor here, the capnogram. So you can see the way the amplitude of this is like a nice breath that she took. You can now see the way the amplitude is starting to go down, and here she became apneic. And here, I said, Marianne, take a breath, and you can see the resumption of breath. So this is what I was meaning by how capnography is real-time apnea, whereas pulse oximetry is going to be 7, 8, 9 minutes before the pulse ox is going to start dropping. So capnography is really, really a key monitor. So the last thing that I really want to say is that, your doctorate in dentistry basically gives you the tools that will provide you with huge success in doing moderate sedation. And what I mean by that is, first of all, you're experts in blocks, so you know how to anesthetize the teeth. It's crucial to moderate sedation because with a good block, it's really going to reduce the amount of sedation you're really going to need to perform the procedure, and it improves safety for the patient. Other things are you're experts in nitrous oxide. I mean, you've been taught how to use nitrous. You use nitrous quite often. It's something that's really important and to have available to you. So, for example, let's just say an adult patient comes with like just tremendous fear of dentistry. Typically, it's the needle. When they're putting the block in, that's one of the things that really freaks people out. So maybe put on a little bit of nitrous. So early on in the case, use 50% nitrous just for the needle, get the block in, then turn the nitrous off, titrate with a little Versed and midazolam. And that's all you really need to do. Thirdly, you're experts you understand what the TMJ joint is, and as I was taught by Ariana, it's a ginglymo-orthoidal joint, which means it has two motions. It's the only joint in the body that has two motions. It's a hinge and it's translational. It's this translational property of the TMJ joint that allows this jaw lift, chin lift, the jaw thrust chin lift maneuver, just called really mandibular advancement. What it really is defined really as is the lower incisors come or move such that they're beyond the upper incisors. That's what mandibular advancement is. That's what opens the airway when you start getting this hypopharyngeal collapse during sedation. The other thing is you'll be a professional peer with a dental surgeon. So it's not like going to be a hierarchical thing where you got the big doctor and you're doing the sedation. You guys are equally have doctorates in dentistry. So you're peers. So as a result, it's important to be able to get buy-in, let the proceduralist know. Nerve block is key. It's going to make things safer. It's going to minimize sedation, and it's going to also provide postoperative analgesia. So when the patient leaves, you're not going to be having to give opioids and stuff. The block will be useful, and I recommend Tylenol and NSAIDs scheduled like Q8 hours for like 2 or 3 days, depending on the procedure and how much pain you're going to have with it. Scheduled NSAIDs plus Tylenol, or as you probably know, are really, really efficacious. They can decrease the need for opioids by 30 to 40% in like general anesthesia patients. And the other thing that you have to get buy-in from is that you've got this open airway, and so aspiration is possible. So you have to be, you also have to get the assistants working with the proceduralist on board, because they might not have much experience with this, and just make them aware that that the airway is open. Make them also aware that the patient is breathing, and make them aware of their position. Sometimes a patient's leg might fall off the dental chair. So you have to just always be cognizant and have somebody checking to make sure that, like a positioning injury doesn't occur by the leg kind of falling off the chair and nobody really being aware of it. So there really needs to be buy-in from both the proceduralist, his staff, and you. And it's your duty to really educate them, in a collegial manner. So the aim is to really complete the procedure with the least amount of sedation. If a patient moves, ask the dentist to please give local first before giving more medicine, and that's the way you can, these are things that are going to keep you out of trouble. All surgical assistants must also be aware it's an open airway, risk of aspiration, minimal sedation, minimal irrigation, not huge bowl, just sedation, just irrigation to just kind of clean out the area for exposure for the proceduralist, and then timely suctioning so that stuff doesn't start going down the airway. And then, as I said earlier, some of you might not really be interested in actually performing moderate sedation, but moderate sedation, by you requesting moderate sedation where you're the proceduralist, can actually increase the number of patients that you can do as a dentist, and just grow your practice better. So I'm going to stop here because I had other slides. Maybe we can come back for a second talk. This just deals with the perioperative phases of care, which are preoperative, intraoperative, postoperative, post-discharge. We can do it another time. So then the next thing I can do is just go to, this is just quickly like what a capnogram is. So what this capnogram really is so this is really at the end of inspiration. And then as expiration occurs, maybe if I go back a bunch of slides to this here. So what happens with expiration is, from the mouth to the alveoli, well, from the mouth to the bronchioles here, the bronchus, is dead space. So there's no end-tidal, there's no carbon dioxide in here, because this isn't exchanging CO2 with the blood. That exchange happens down here. So the original, I'll go back to the capnogram. So the original capnogram starts rising because at first there's no CO2, And then as you go deeper and deeper in the lung, more and more CO2 comes down until you get to the alveoli, where you get the actual plateau. And then with inspiration, then with expiration, you get, the decline in the capnogram. So here. So basically what's happening is this is like dead space. So this is just the air coming from like the mouth, the trachea, now it's coming up to the alveoli. Now this is the plateau. And then this little right angle here is the actual end tidal CO2. And then you have the inspiratory downstroke. So that's something I think is just important to know. Just again, to just review the references, and I recommend, I urge you to look at these and try and read these articles. I think they're interesting and useful. This is the moderate sedation guidelines. That is the definite basic document that all of you we're doing procedural sedation should be aware of. Be aware too of the potential harm from dental treatment. Aspiration. This is the Mendelsohn syndrome, his article. And then this is a really interesting article talking about the different dental materials that have been aspirated. And it talks too about the radiodensity of these substances and recommending that if you can use dental materials that you're able to see with X-ray, that adds a margin of safety to the patient. And then the upper airway collapse, this article by Hillman talks about sleep apnea and sedation and how the airway can collapse. The head up position, these are the two things that say you'll increase safe apnea time with the head up. And then here, I just want to say, you can go to this thing. It's the Stanford sedation model. It's not coming out. There it is. And so just go to this link, click on it, enter your information, and if you can go forward. It's not going forward for me. It'll just ask you for your name and your organization, and then it's a really useful cognitive aid that deals with a lot of the emergency situations that happen. So that's pretty much all I have. Any questions, or is it close for you guys to go back to work?
We do have patients that just showed up, so yeah, we probably need to be back, but I don't have any questions. Yeah, it was really thorough.
Thank you.
Yeah, thank you for that. That was awesome.
All right, great. Thanks so much. And best of luck to you all, okay?
Thank you.
Thank you very much. General questions, yeah.
Not at the very moment.
We probably will at the end, I'm guessing.
Yeah, probably as we go through the presentation.
Okay.
Not right now.
Just things that you might have wondered about, or
We do IV sedation here, which I'm sure Ari's told you about, like
yeah.
for wisdom teeth extraction, actually only wisdom teeth extractions. So we have a little bit of experience doing that. I'm sure we'll probably have some questions at the end.
Any issues arise that you have questions about?
I'm trying to think, like,
Well, how about if like looks like the airway's starting to collapse, what do you do?
what we've been taught to do is, so we have an oral surgeon that comes in, Dr. Solano, on Mondays and helps us. He'll like grab their tongue and like pull it out to like make them react.
Right.
Or I've seen him grab their ears really hard and pinch their ear, pull their ear. But I don't know if that's like the best way to do it, but that's one way that I've seen him do it.
By definition, that really means you're actually at the level of deep sedation, no longer in the level of moderate, because you've lost the ability for the patient to follow verbal commands. But typically the jaw lift and chin thrust maneuver is something you can do quite easily. Because if somebody is fighting you and has their mouth closed and they're obstructing, you're not going to be able to go in there and necessarily grab the tongue, but you can always do a Ramus lift, and that typically will open the airway. I have a video in the slides that show how to do the chin lift, jaw thrust, and how to do bag mask ventilation if for some reason somebody goes apneic and you have to take over their airway. Bag mask ventilation with an ambu bag is the way you would deal with that.
Yeah. So yeah, Solano is sedation, but then Medlin, the other guy who comes in, is very moderate sedation. So we've done the jaw thrust thing. What'd you call it? The lingo? What was the maneuver?
It's a jaw thrust or a chin lift or jaw thrust maneuver. It's really just taking your hands on the ramus and lifting them up.
Okay, that's what you're saying.
And you're just, what you're doing is you're taking advantage of the translational property of the TMJ joint. You know, if you can just advance the mandible away from the posterior pharynx, you'll open the airway with that maneuver. So typically just what, 2 fingers just on the ramus lifting up is all you really need to open the airway. And quite often you can get your hand in there and not interfere with the dentist who's trying to, chin lift. If you're doing it from here, you kind of interfere with the procedure list, but the ramus, you can kind of come from behind and just elevate the ramus and typically will open the airway.
Sure.